This conference will now be recorded.
Okay. Okay, we'll start. So today we will talk about the trigeminal nerve, nerve 5, no conflict of interest. So the objectives, we'll talk about first the anatomy of the cranial nerve 5, then the clinical evaluation of cranial nerve 5 function, then how to localize the lesion if it's affecting the nucleus or the periphery. Starting with the anatomy of the cranial nerve, trigeminal, as we know, is the longest, largest nerve in the body. It's a mixed nerve, consists of sensory and motor. The sensory innervate the face and the mucous membranes of the oral and nasal cavities, and the motor innervates the muscles of mastication. We will talk about it in details. So this is just a big view, starting from the brain stem on the right side, where all the nucleus are there, then the tracts in between, then the Gasserian ganglion, then moving to the branches. We'll take a closer look and talk about each in details. So starting with the motor is easier because it's only one nucleus. So the motor nucleus of the trigeminal nerve is situated in the mid-pontine level, medially to the main sensory nucleus, near the floor of the fourth ventricle. It receives the supranuclear control, of course, from the corticobulbar fibers from the lower third of the precentral gyrus, and it has bilateral connection going down through corona radiata, internal capsule, cerebral peduncle, down to the bones before decussation and supplying the motor nuclei. Of course, you will not remember anything unless we see a picture. So starting, everybody can hear me well?
Just, I need yes, please.
Yes, we can hear you, Rola. Yeah.
Okay, perfect. So starting from the cortex and down, just a little reminder of the tracks down to the nucleus and the midbrain and the pons. Sorry. So here is a closer look. So you can see the motor nucleus, one nucleus only in the medial side in the pons, and then the all the other nucleus, the sensory nucleus, starting from midbrain, pons, and down to the medulla and spinal cord. We'll talk about it later in detail. So just see the site of the motor nucleus in the mid-pontine area. The motor route, they call it portia minor, exit from the motor nucleus, passes forward in the pons, as we mentioned before, medially to the sensory. So they call the sensory is the portia major, and the motor is the portia minor. So then it goes down during the course from the pons down to the dura mater, to the apex of the petrous bone in the Meckel's cave, travel beneath the trigeminal ganglion and leaves the skull through the foramen ovale. Why it's important to know the origin and the course, just for later when we talk about the lesion, we know where from it's coming, and we can relate all the lesion according to the place. So here a better explanation. As you can see, the motor route comes from the bones on the left, going above the petrous bone, and when it leaves from the foramen ovale at the end, it joins the mandibular division. The red line, this is the motor route. And this is the Meckel's cave in the temporal bone, whereas the trigeminal ganglion and the motor nerve pass with it down. So after leaving the skull, as we said, the motor route join the mandibular division, like we saw in the previous image, to join the mandibular nerve and form the mandibular nerve, which supplies the masticatory muscles. And the masticatory muscles are the masseter, temporalis, medial, and lateral pterygoid muscles, plus the other small muscles, tensor tympani, tensor villi palatini, mylohyoid muscles, the anterior belly of digastric muscle.
and the better is to see a picture to remember. So the temporalis muscle, like we said, and both the lateral pterygoids and the masseters. And the small muscle here on the right, the graph, the tensor veli palatini to support the palate. And on the left, it supplies also the small tensor tympani muscle, which is dampens the main function of this muscle is to dampen the sound. Like when we chew, we don't hear the loud sound in the ear because of the help of this muscle. And support also the floor of the mouth from the mylohyoid and the anterior belly of the digastric muscles. So this is the motor portion, straightforward and easy. The more complicated, a little bit sensory portion, because it's long and 3 parts. So starting from, you can see here on the right, from the Gasserian ganglion, which is situated also, as we saw before, in the apex of the petrous bone in the middle cranial fossa. It will stretch up to the midbrain and give the mesencephalic nucleus. Mesencephalic is called because it's in the midbrain from the mesencephalon. And the second nucleus, it's in the middle of the pons, which is near to the motor, which they call the principal sensory nucleus. Then down to the medulla, there are 3 different nucleus. This long nucleus through the medulla, calling the nucleus of the spinal tract. And this nucleus and the medulla is 3 parts: pars oralis, interporalis, and caudalis. So again, remember the sensory nucleus is the 3 parts. First part in the midbrain, the second in the pons, and the third in the medulla. So these sensory fibers, when they enter the medulla, they make a bundle and they make the spinal tract of the trigeminal nucleus to the caudal end of the medulla, caudal, which is down to the end of the spinal cord as far as the 3rd or 4th cervical level. This nucleus, as we mentioned, divides in, and this is like repetition of the above, we can from where to where, these are 3 parts. So here what is important clinically, as this part, if you correlate it with the colors, if you see down, as we go down, like the spinal nucleus, what we call pars caudalis, which is at the end, it's responsible for the sensation of the lateral side of the face or the outer part. And as we go up, it's more central. And the trigeminal here, the up one is responsible for the sensation around the nose and the mouth. This is what we call the onion skin arrangement of the sensation. And this is important to know because it will help you localize the lesion when it is in the medullary portion or the upper cervical part. And this is the same. So the spinal nucleus, what is the function of these 3 nucleus of the sensation? So the long one, which is the spinal nucleus, receives fibers, it's responsible for almost the pain, soft touch, and the cold and hot, the temperature. The main sensory, which was in the pons, the one in the middle, responsible for the tactile and the proprioception, and the one in the midbrain above, the mesencephalic nucleus, responsible mainly for the proprioception impulses from the masticatory muscles and from also the muscles supplied by other motor cranial nerves. So any question about the motor and sensory nucleus? Okay, I'll move on. So we talk about the nucleus in the brain stem. Moving forward about the division giving, we know that there are 3 divisions: ophthalmic, maxillary, and mandibular. Just remember the V1 and V2, the ophthalmic, maxillary, are sensory, purely sensory. divisions. And the third one, the mandibular, is the one which will give mixed motor and sensory together. So each division supplies big portion of the face. Starting with the ophthalmic division, we can better move to the picture. Yeah, this is a nice graph telling you when it's coming out from the skull, it leaves the skull, like the ophthalmic nerve leaves the skull through the superior orbital fissure. The maxillary leaves through the foramen rotundum, and mandibular leaves through the foramen ovale. I found it comes in MCQs, a question on the course sometimes. And you can also relate in case of the trauma or near the foramen, or like which division is closed. So it's a nice graph to go back to when we face a question. So back to the ophthalmic division, supplies the skin of the nose, upper eyelid, forehead, the scalp, as far as the back as the lumboidal suture in the midline, 8 cm lateral to the midline, supplies also the cornea, conjunctiva, and iris, and the mucous membrane of the frontal, sphenoid, ethmoidal sinus of the upper nasal cavity and septum, and the lacrimal canals, and the dura mater as well of the anterior cranial fossa and falx cerebri and tentorium cerebelli. And these are the division. You can take your time and read. It's a lot of branches. You can read it later. So the most important division, you can see this is easier graph on V1, ophthalmic to the skin above the orbit, the lacrimal, supraorbital, supratrochlear, infratrochlear, external nasal nerve, the one in purple, and here you can see the division of the maxillary and mandibular. So moving to the maxillary division, the maxillary supplies the skin of the lower eyelid and the lateral nose, upper lip, and the cheek, and the mucous membranes of the maxillary sinus as well, with lower nasal cavity, hard and soft palates, upper gum and teeth of the upper jaw, and the dura mater of the middle cranial fossa. Then the last part, the mandibular. As we mentioned, the mandibular joins the motor root to form the mandibular nerve, and it leaves the skull, as if you remember from the previous graph, through the foramen ovale, and it travels in the infratemporal fossa, dividing finally into also several terminal branches. The important branches here to mention, we have the lingual nerve, which conveys the sensation from the lower gums and the papillae and the mucous membrane of the anterior 2/3 of the tongue, and inferior dental branches to supply the lower gums and the teeth, and the mental branches. I will mention the importance later in the pathology. But just keep in mind these branches, the mental, especially the mental and the lingual. The mental branches, after emerging from the bone of the mental foramen, supply the skin of the chin and the skin of the mucous membrane of the lower lip. Here is the mental branch, inferior dental branch, the lingual nerve, motor branches to muscles of mastication. And again, to remind you about the graph, so it supplies as we mentioned before. Just remember here, it's important that it supplies the anterior 2/3 of the tongue, but not the taste sensation. The taste is carried by the facial nerve, but the sensation is for the fifth. And that's about the division. We're done with the anatomy. Any question? Okay. So moving to the clinical evaluation. How do we evaluate it clinically? As we explained, there are 3 parts: the sensory part, motor part, and reflexes. Starting with the easy one, how to, as we do in our daily life, we test the pain, light touch, heat, and cold, on the face and the mucous membranes. Each of the 3 trigeminal division tested individually and compared to the other side. Keep in mind that the lesions, if it is distal to the ganglion, can result, if it's like in the periphery, it can only affect the cutaneous supply, of course, over the area supplied by the peripheral nerve, but if it's affecting the ganglion itself, it can result in loss of the whole ipsilateral face sensation. And if the lesion in the brainstem or the upper cervical cord, remember the onion skin distribution of the sensory loss. Just remember, keep in mind that the cutaneous area over the angle of the mandible is not supplied by the trigeminal nerve, which you can see on the left side of the guy face near around with the normal skin color. This is supplied by the second and third cervical roots from the cervical plexus and not by trigeminal nerve. This is important when a patient can come like with numbness or loss of sensation, sparing the angle of the mandible, then it is still significant and can relate to trigeminal, or it can differentiate if it's related to the cervical plexus or the trigeminal nerve itself. And this is, we all know. So this is the sensory part is easy. The motor evaluation, we test the muscles of mastication. Of course, we tested by when asking the patient to clench his jaw, you are testing the masseters and temporalis, and moving the jaw from side to side, and you are testing, in this case, the lateral pterygoids. And if there is, if the nucleus or below the nucleus, the motor division is affected, the temporalis and masseter on the same side of the lesion do not contract when the jaw is clenched, and the jaw deviates to the paralyzed side. This is always confusing, which side is the lesion. So it is the paralyzed side, the jaw will move towards it. Why? Because the jaw is like both muscles to contract and push against each other to keep the mandible in the middle. So when there is one side is weak, this side, the other side will keep pushing, so it will go to the bad side. So remember, the paralyzed side is the one where you see the mouth deviation. So as I mentioned earlier, so the left side, it is deviated toward the left, means it is the lateral pterygoid which has the problem. After the motor, sensation and motor, we test the reflexes. And reflexes, there are three major reflexes here. We'll talk about the first one, which is the corneal reflex. Just remember, for the corneal reflex, we need intact not only fifth nerve, but also seventh nerve, because the afferent, the sensation goes from the cornea, travels through the ophthalmic division, but the efferent moves through the ipsilateral, which is the direct, and contralateral, consensual facial nerve to give a signal to the orbicularis muscles to close, because obviously you cannot close one eye and it's like a defense mechanism. You need to close both eyes in case of any threat. So, and this is a nice graph. You can start from up there, from the corneal stimulation up to the down to the ganglion. It will give the sensory, it will give axons and fiber down to the, if you can follow number 3 to the 7th cranial nerve. It will, the sensation also will go down to the spinal nucleus all the way down, then give reflex sensation. This is the ipsilateral and consensual reflex to the other, also 7th cranial nerve on the other side, and will close both eyes. The second one is the jaw reflex. The jaw reflex, or we call it the masseter reflex, involves contraction of the masseter and temporalis when the patient's lower jaw is tapped. And you need only the fifth nerve for this reflex, because the afferent and efferent in the same nerve. The afferent, going through the motor fibers in the mandibular division, goes to the mesencephalic nucleus which was in the midbrain, and the efferent will go through the mandibular fibers from the motor. Again, it will give the sensation and will give the motor fibers again to close the jaw. So anything between this circle, anything affecting from this circle can cause a lesion anywhere in this arch. So it's monosynaptic because it requires only fifth nerve. And as we know, so how we do it, you ask the patient simply just to open his mouth slightly and tap on the jaw, and it's brusque reflexes lead toward upper motor neuron lesion, but if the nucleus is affected or infranuclear, the reflex is absent. And the third one is the glabellar reflex or the blink reflex. Tapping over the supraorbital ridge results in bilateral contraction of the orbicularis oculi, and the afferent is mediated by ipsilateral main sensory nucleus, the main sensory nucleus, which is in the pons, and ipsilateral, contralateral, and goes down also to the spinal nucleus. And then from the spinal nucleus, it gives the signal to to both the seventh cranial nerve for the orbicularis oculi muscles for the help to close the eyes. Usually we don't test these regularly, imported from the corneal reflex. Any question? Are you still with me, guys? Hello?
Yeah, we're with you.
Yeah, with you there.
Yes.
Okay, I hope you can remember from the pictures the anatomy, and so we talk about the major, the anatomy, the course of the trigeminal nerve and how to test it. Then I will talk about the localization of the lesion affecting the cranial nerve 5. We can divide it and think about it. If it is supranuclear, anything comes from above, from the cortex or the corticobulbar fibers, or going down to the nucleus itself, then moving to the lesions affecting the preganglion, which is the nerve roots between the nucleus and the ganglion, or lesions affecting the ganglion itself, or from after the ganglion and the branches. It's a lot of, it is very extensive, so I picked a few examples for each lesion, which is, I found it interesting. And so this is just a reminder, as we said, either in the nucleus itself, between the nucleus and the ganglion, and after that, the branches. So just keep the picture in mind, try to locate the lesions. Supranuclear, as we mentioned earlier, because it receives all the way from the corticobulbar fibers, from the frontal motor cortex, and descend down through the corona radiata, internal capsule, cerebral peduncle. So lesions, any lesion interrupting this pathway, and this is very common, like we see in the stroke cases, can interrupt the function of the trigeminal nerve. Just remember here, the deviation of the jaw will be away from the lesion, but this is why, because there is contralateral, the left side controlling the right and the opposite. So let's say the lesion on the left side actually controlling the right side of the nucleus, gives innervation to the right side. So it's still, so the lesion in the brain will be the opposite. But the lesion, when it is lower motor in the nucleus, it will be the same side of the lesion. I hope I explained this well. So if it is upper motor, it will be, the lesion will be opposite to the side of the jaw deviation. If it is lower motor, it will be the same side of the jaw deviation. So if it is affecting the from the motor area, of course, it will affect the muscles of mastication. If it is if the lesion in the thalamus, it can cause anesthesia of the face, and so it depends on the. This is very common, we see in stroke cases every day. So moving to the nuclear lesion. Nuclear lesion, anything can affect the nucleus itself. Can be tumor, metastasis, AV malformation, demyelination, infarction, hemorrhage. The list is big. So the nuclear lesion, how we can tell? Usually they don't come alone because there is a lesion obviously there, and it's not picking only the nucleus. Usually there is another association. So the company they keep, like the long tract signs or other cranial nerve involvement. So we can tell if it's affecting the nucleus itself. There are a few things which can only affect, like very rare, but it can happen that it will only affect the nucleus. Like there is a known entity known the lateral pontine tegmental hemorrhage. It can present rarely as an isolated trigeminal sensory neuropathy, which is only numbness and paresthesia of the half of the face, like in the trigeminal, because it's affecting the main sensory nucleus of the trigeminal nerve. So it's like very small lesion, hemorrhage only on this area. It can affect only the sensation. And an example also, if it is a small infarct, like left dorsolateral pontine infarct, also presented as orofacial sensory deficit. So it is possible, and numbness also can, isolated numbness also can present a small hemorrhage or a small infarction. Patients with dorsal pontine lesions, usually tumors, it's not also common, but it can happen. A tumor in the dorsal pontine can cause unilateral spasm and contracture of the masseter muscle and impair the ability to open the jaw and forcing the patient to speak through the teeth. They call it hemimasticatory spasm, which is a rare disorder of the trigeminal nerve and involving the jaw closing muscles on one side of the face. And actually, you will see the involuntary jaw closure due to paroxysmal unilateral muscle. So the spasm, it can come as a spasm, which is sudden and brief and lasts several minutes and cause intense pain. And actually, they noticed with the explanation for this, that why this hemimasticatory spasm can happen because of ectopic excitation when the nerve is entrapped between the masseter and temporalis in its course between, the lateral pterygoid muscles and the skull, causing focal demyelination and the spontaneous discharges. So hemimasticatory can indicate a tumor, like we said. This spasm is ominous sign. If you see a patient with spasm, hemifacial spasm, MRI here is indicated, searching for could be tumor. And also it could be a sign with localized scleroderma. So it's also important to check and ask about the other rheumatological and connective tissue diseases. And of course, history here will help if the patient had surgery or can also indicate of vestibular schwannoma. Moving to lesions affecting the preganglionic roots before the ganglia. So the damage suggested by involvement of the neighboring cranial nerves. Usually it accompanies the surrounding cranial 6 and 7 and 8. And the roots here usually comes with facial pain is the presenting symptoms. Of course, with the numbness and sensory loss, and corneal reflex might be affected and depends on the nerve involved. So the trigeminal roots may be involved by extension of pathological process, usually meningioma in this area or acoustic neuroma, because it's close to the CP angle. And as I mentioned, usually comes with the pain and depends if the cranial nerve 7 is involved, can come with ipsilateral deafness, tinnitus and deafness and vertigo, or if the facial is involved, or usually if it depends if the 6 or 7 or 8 is involved. Trigeminal neuralgia is very well known to us. Just a few words about it. A trigeminal neuralgia is a distinctive syndrome As we know, it is sudden, excruciating, paroxysmal, lancinating pain with usually unilateral on the distribution of over one or more division, usually on the maxillary and mandibular. It is very rare over the ophthalmic, so mainly involving the maxillary and mandibular division. And it's very rare to have bilateral trigeminal neuralgia, except for cases for MS, for multiple sclerosis. And these are very painful and very brief, can recur up to 100 times even per day. And these painful paroxysm, of course, are triggered by any facial stimulation. And it's often, if it's affecting the V2, usually the complaint from pain refer to the upper lip, nose, and the cheek. If it's in V3, affecting also the lower lip. And as I mentioned, it is very uncommon to affect V1. Although it is called idiopathic, and I believe like lots of people, they just diagnose it clinically, but actually 10% of the cases is idiopathic, and the majority they have, it's mentioned in the literature that they have other causes. So it's a must that we look for other causes before calling it idiopathic. Because any lesion affecting the brainstem, the root, the ganglion, peripheral trigeminal nerve, and because of any irritation, demyelination, any lesion around it can cause irritation and can cause this trigeminal neuralgia. And very frequent reported the superior cerebellar artery, also aneurysm or compression can cause the trigeminal neuralgia. So just remember to look for other causes before calling it idiopathic. Moving to the lesions affecting the ganglion itself. Remember when I showed you the first picture, the ganglion and the middle cranial fossa. And so anything there from tumor, infection, abscess can directly damage the ganglion at the Meckel's cave. And it also comes with pain. Pain is the main symptoms here. Severe and paroxysmal with characteristical findings of hemifacial, or can either the whole face or can involve division. Depends if it's like on the ganglion, the whole ganglion, or it's near the roots. Multiple also cranial neuropathies can occur in primary amyloidosis. So always search for underlying causes. So it's reported also that the rheumatological diseases, especially Sjogren rheumatoid, systemic sclerosis, SLE, Sjogren-Strauss, they present with facial numbness they present with the facial numbness, and they found a lesion or actually inflammation in the ganglion. And the trigeminal symptoms can develop before the connective tissue diseases in 7% of the patients, and concurrent with the symptoms in 47% of the patients. And the reason why it's affected in these rheumatological diseases, the inflammation happened because of the permeability of the to proteins. So the lesion is suspected to involve the trigeminal ganglion or proximal part of the main trigeminal division, and perhaps related to capillaries of the ganglion being more permeable than the brain capillaries to abnormal proteins. And this is the explanation why. And also can happen, so other causes of the ganglion damage itself because of a trauma, or as I mentioned before. So again, think of tumor, infection, or connective tissue diseases. Moving last to the lesions affecting the peripheral branches of the trigeminal nerves. So first, the ophthalmic division. If you want to think about the peripheral division of each nerve, just remember the course and where it runs and the surrounding areas. So again, it may be damaged on the the course of the middle cranial fossa and the temporal bone. So anything happened there from trauma, a tumor, infection, anything localized, again, it will cause a problem. The maxillary division may be damaged again at the, I'm gonna skip this. So I want to mention here, yeah, I'm gonna skip the lesions. Yes, lesions in the infraorbital foramen may cause, this is very interesting, the numb cheek syndrome, in which numbness involves one cheek and the upper lip and the infraorbital nerve distribution. And the hyposthesia may involve also the medial and lateral, the upper incisors of the teeth and the gingiva. In the 2/3 of patients, actually it is interesting because the numb cheek syndrome can indicate that there is a squamous cell carcinoma of the skin. Because of the proximity of the distal branches of the facial nerve as well to the infraorbital nerve, lesions of the face, especially squamous cell carcinoma, can affect also the muscles of the upper lip and angle of the mouth. So it either can, and they call it the numb cheek limb lower lid syndrome. So if it affects only the fifth nerve, it will cause only the sensation. If the also the movement involved and there is weakness, it affected the seventh. So I find it interesting because a lot of people complaining of non-specific numbness here and there in the cheek and the lips, and it's not significant with no other symptoms, but it actually can indicate cancer. There is also another, the musicians usually who play the brass instruments, the continuous pressure can cause injury to the anterior superior alveolar nerve, resulting in upper lip numbness and pain. So this is also, I remember they called me from, hello? Yes, I got consultation before from Heart Hospital for a patient with only upper lip numbness. And actually they did the CT and MRI from, I think it was Heart Hospital. And they were investigated her thoroughly, and she had only numbness of the upper lips. And when I took the history from her, and she was intubated, and she stayed long time on the intubation and after cardiac arrest, and she recovered. So it was only because of the pressure. So people need to understand that some numbness, take history first. It could be some pressure and there is nothing behind. But again, if you couldn't find an explanation, you need to go further. There is another syndrome also. So we talk about the numb cheek syndrome. There, the mandibular and the maxillary. The mandibular division of the trigeminal nerve also may be damaged at the foramen ovale or in the zygomatic fossa or in the face. So the lesion in this area can affect the sensation of the ipsilateral masticatory, can cause ipsilateral masticatory paralysis. There is a syndrome of isolated mental neuropathy, which they call the numb chin syndrome, which consists of pain, swelling, and numbness only of the jaw at the lower lip, chin, and the mucous membrane on the inside of the lip. So this syndrome usually seen in patients with systemic cancer, especially carcinoma of the breast and lung, and maybe due to compression of the mental or inferior alveolar nerve by metastasis to the jaw. Or could be because of leptomeningeal seeding or a neoplastic perineural infiltration of the mental nerve. So numb chin is very important. Numb chin alone also, this is a reason that you need to look also for other causes or cancer. And remember, the damage will be the inferior alveolar nerve damage. It can also be a sign of multiple myeloma or the presenting sign of Burkitt lymphoma in HIV infection. And here is the mental innervation. And you can tell it's a proximal versus distal origin of the syndrome, depends on the presence or absence, of course, of other cranial nerves involved. So the estimated frequency of the numb chin syndrome in breast cancer is approximately 4%, usually associated with poor prognosis. Therefore, patients who develop non-traumatic mental neuropathy should undergo careful search for malignancy and the chin numbness that occurs in patients if they are known to have cancer may indicate relapse and metastasis. Another study, and of course there are other causes, mostly due to dental causes, anesthesia, complications of dental procedures. And the numb chin syndrome also described as the first sign of giant cell arteritis. Bilateral numb chin syndrome has been described also as the initial symptoms of Burkitt lymphoma and acute lymphoblastic leukemia. They found the reason as direct infiltration of the mandibular nerves by leukemic cells, burning sensation of the lower lip, followed later by numbness, may also occur with sickle cell disease because of infarction of the inferior alveolar nerve. And also can happen in cutaneous carcinoma of the face and the nasopharyngeal carcinoma. So these things make it difficult to differentiate the benign trigeminal neuropathy from the serious conditions, like what we mentioned. The other also interesting thing is the tongue numbness alone, either unilateral side or bilateral, can happen of sudden onset, may be seen with temporal arteritis, likely the ischemia of the because of brainstem or lingual nerve is responsible. The tongue numbness may be part of the neck-tongue syndrome, in which there is a sudden turning of head results in pain in the upper neck and the occiput, lasting around 1 minute, followed by numbness of the ipsilateral half of the tongue, lasting seconds to 5 minutes. The symptoms always triggered by rotation of the neck to the same side as the pain and the numbness. It has also associated symptoms with dysphagia and dysarthria. So this syndrome thought to be because of irritation of the second cervical dorsal root, which carries proprioceptive fibers from the tongue through the hypoglossal nerve and has communication with the second root. So don't ignore tongue numbness from now on. So it can also happen with the trauma, or can happen with collagen, also reported with collagen vascular diseases. And of course, secondary to dental procedures, endotracheal intubation, temporomandibular joint dislocation. And it's reported as well in as a manifestation of Guillain-Barré syndrome, like a change in the sensation with numbness. Last thing, I will talk about the jaw drop. Jaw drop is a weakness of the jaw closure muscles with a preservation of the jaw opening muscles, the pterygoid muscles. When severe, the jaw can hang open or be dropped. So the patients have fatigue of the chewing and need to manually support the jaw. Why it's important? Because it can indicate myasthenia gravis or ALS, or myotonic dystrophy. So in ALS, the jaw drop is rarely an early feature. Rather, the tongue muscles are frequently the earliest and most severely involved, suggesting that the hypoglossal motor nerves are particularly susceptible in ALS. So, and there is a disease called a Kennedy disease. They can also present with jaw drop and isolated closure weakness. Kennedy disease, or they call it a spinal and pulpar muscular atrophy, inherited X-linked degenerative disease of the sensory and motor neurons caused by CAG repeat expansion. The distinguishing here clinical feature of the disease is the slowly progressive proximal greater than distal limb weakness with pulpar weakness involving the facial and tongue muscles with perioral fasciculations. And so it's a constellation of symptoms with also elevated creatine kinase and androgen insensitivity. And jaw muscle weakness is a differential indicator of a neuromuscular weakness. So in series of patients with a flaccid quadriparesis, the presence of jaw closing weakness pointed toward myasthenia, as we mentioned, and whereas the presence of jaw opening weakness can indicate the polymyositis, dermatomyositis, and it's a muscle if it's the opening, but the jaw closing is a neurological more with myasthenia. Guillain-Barré syndrome patients very rarely also had jaw muscle weakness. Just in a summary, try to remember each what is affecting the nucleus, what is affecting the preganglionic, ganglionic, and the peripheral nerves. It can be anything simply. So history is important, and the association of other symptoms is very important. So take home message: non-specific numbness is specific. And what we call lots of times is just a psychiatry, and this is functional, might not be functional. And the human brain is one of the most complex single objects on the face of the earth. Thank you. Any questions? I hope you're still around. And any questions, guys?
Thank you. First, thank you, Rola, and I'm apologizing for everybody for the delay. It was out of our hand.
I'm very sorry.
In the future, yeah, because I mean, we had many people. Actually, we have the first time somebody from Palestine joining us, and we have Sidra. So hopefully in the future it will not happen, and we'll get in a better way to make sure that it works better.
Sorry, I didn't expect this limited number of attendees.
I mean, we had up to 16 people attending, actually, the meeting.
I think there was a problem in my account. I'll do a new one.
Yeah. Don't worry. I'll take care of that for the future. But you did a very excellent job. It was very thorough. You can stop the recording now if you want.